You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for December 1st, 2023. This week, we'll have more from the AHA. This includes SGLT2 inhibitors after MI, blood transfusion strategies after MI, a crack in the armor of factor XI inhibitors, and more on renal denervation. First up is the DAPA MI trial. This was presented at AHA. The SGLT2 inhibitor class of drugs have as positive both tons of empirical data, and they're also easy to use. In chronic kidney disease, in diabetes, in heart failure, there are clear benefits. Now, we can debate cost efficacy, but there are surely benefits. What about in post-MI patients? Swedish investigators, first author Stefan James, tested the idea of adding Dapagliflozin to patients after an MI that either left the patient with a Q wave on the EKG or mild left ventricular dysfunction. I'm sure, why not, they thought. Post-MI care has plateaued in the post-reperfusion era, which makes perfect sense because stopping MI before it causes damage is really hard to improve on. But gosh, these SGLT2 inhibitor drugs are so loved, they should be tried. Now, before I say anything more, the trialists have done a very nice job. Yet, DAPA MI is going to require its consumers, you and me, to really wear our thinking hats. The original trial plan, though, had to be changed. Originally, the trialists planned to look at hard clinical outcomes like cardiovascular death and heart failure hospitalizations. They then discovered a problem. Post-MI patients, even with mild left ventricular dysfunction or Q waves, don't have many bad events. This left the trialists few choices. Choice A, they could just forget doing the trial. Choice B, they could enroll tons more patients, which is costly, or they could change the primary endpoint. So they changed the primary endpoint. Now, they didn't look at the data. They now decided to look at a bunch of cardiometabolic data in addition to the hard endpoints. Now, I want you to sit down for this because it could be the bulkiest primary endpoint I have ever read. The primary now included a hierarchical composite of death, hospitalization for heart failure, MI, AFib, type 2 diabetes, New York Heart Association functional class at the last visit, and a body weight decrease of 5% or greater at the last visit. They analyzed this using the win ratio analysis method. The key secondary outcomes was the same hierarchical composite excluding the body weight component. Now, for the win ratio analysis, what they do is matched pairs are created between the two arms. Then each strategy assigned a win or a loss per pair, starting with the worst endpoint, death, then moving down the list sequentially if the previous event did not occur. A win ratio is a way to use all of the data. That's a positive, but its downside is that it's kind of hard to apply clinically. DAPA MI enrolled about 2,000 patients per arm very soon after the MI. These were 63-year-olds. Only about 20% were female. This was from the UK and Sweden. 20% of the patients had normal EF. Many had STEMIs, but non-STEMIs were allowed. Patients had normal kidney function. These patients were already on really good therapy, right, with high percentages of ACE-AR, beta blocker, and of course, antiplatelet drugs. Now, the bottom line is that DAPA MI is technically a positive trial. The analysis of the primary hierarchical composite outcome resulted in significantly more wins for dapagliflozin than for placebo. The win ratio was 1.34. 95% confidence intervals went from 1.20 to 1.50, and the p-value is highly significant. Now, the problem and the reason for the addition of the modifier technically for positive that I mentioned earlier was that hard clinical endpoints like death, CV death, heart failure hospitalization, MI, stroke, and even all-cause hospitalizations were not different amongst the two groups. The primary endpoint of DAPA-MI was driven by softer endpoints like new diagnoses of diabetes and weight loss, both of which were way down that hierarchical scale of the primary endpoint. Adverse events were similar, and I specifically looked at ketoacidosis because we're actually seeing a bunch of these cases in our quality review committee. I think we're seeing these non-hyperglycemic ketoacidosis on SGLT2 inhibitors because it sort of tricks doctors. Now, my comments about the trial, I really like this trial. The post-MI space is going to be a tough place to make a difference in because acute, immediate, urgent revascularization really dwarfs everything else. Now, SGLT2 inhibitors have an important role in diabetes, at prevention of progression of kidney disease, and in heart failure with reduced ejection fraction. But I think the interpretation of DAPA-MI for a clinician is pretty clear. What I would say is there's no compelling reason to use the drugs for a purely post-MI reason. Yes, if there's diabetes or CKD or lowers ejection fraction, but not as a pure post-MI drug, such as a guideline-directed medicine or a quality measure. Now, we wouldn't know any of this if not for the researchers, so I'm glad they did the trial. I also like this trial because it forces us, the consumers of medical evidence, to stop and think about using the results. I also think that the DAPA-MI trial is emblematic of the main challenge for cardiology in the coming decades. That is, it is really going to be hard to improve on what we have now, at least in a cost-effective manner. All right, next topic is blood transfusion for anemia in post-MI patients, the MINT trial, M-I-N-T trial. Now, speaking of having to stop and think about applying trial results to patients, the MINT trial is a real head-scratcher. And the teaser here is that the p-value is going to factor into this thinking, and I love that. Now, the clinical question comes up pretty often, what to do with anemia in the post-MI setting. The two options are restrict blood or be liberal about transfusing. As background, we have, on the one hand, having enough red blood cells may help oxygen delivery and limit damage. But on the other hand, giving blood comes with a risk of things like volume overload, infection, thrombosis, and inflammation. Now, the MINT trial didn't get the big press excitement because industry wasn't involved. But if you practice cardiology and you like medical evidence, I think it's the most interesting trial from the AHA. The previous trials in post-MI patients with anemia are interesting. There's a trial called the Reality trial. It's published in JAMA in 2021, and it found that the restrictive strategy versus the liberal strategy was non-inferior when it came to MACE, major adverse cardiac events, though the confidence interval in Reality included what may be a clinically important harm. The relative risk of the primary outcome was 0.79, so that favors the restrictive strategy, but the upper bound of that hazard ratio was 1.19, which allows for a 19% worse outcome. Now, blood transfusion strategies, be it restrictive or liberal, have been done in many other clinical situations, and there's actually been a Cochrane review of trials of more than 21,000 patients, and it has shown, in general, not just MI patients, but all over clinical situations, a 50% decreased use of blood without differences in morbidity or mortality with the restrictive strategy. Restrictive strategies sort of are in vogue too, at least in my hospital. Now, this is the background of the MINT trial, restrictive versus liberal transfusion approaches in anemic patients who are immediately after MI. Now, in MINT, the restrictive strategy reserved transfusion for a hemoglobin of between 7 and 8, versus the liberal strategy, which allowed transfusions for hemoglobin less than 10. They picked a very strong primary outcome of MI or death at 30 days. About 3,500 patients were randomized 1-to-1. Patients were almost half female. These were 72-year-old patients with normal ejection fraction and a median hemoglobin of 8.6. So the first couple of results are kind of important, but you'd also expect them, right? The mean number of red cell units that were transfused was 0.7 in the restrictive strategy, but 2.5 in the liberal strategy group. Again, that's good because that means that they're actually transfusing blood. This resulted in a hemoglobin level that was 1.3 to 1.6 grams per deciliter lower in the restrictive strategy group than in the liberal strategy group on days 1 to 3 after randomization. Now, the main results are going to be tricky, fun to discuss. Here goes. Death or MI, the primary outcome, occurred in 16.9% of patients in the restrictive strategy versus 14.5% of patients in the liberal strategy. So the liberal looked better, 2.4% in absolute risk reduction. That's an NNT of 42. Now, was this significant? And this is the super hard part. The accrued risk ratio for restrictive versus liberal was 1.16, so 16% worse if you restrict blood. 95% confidence intervals range from 1.00 to 1.35, and we usually say that if 1.00 or no difference was included, it is not statistically significant. But it even gets slightly more complicated than that because there were incomplete follow-up in 20 patients in the restrictive arm versus 37 in the liberal strategy. And so with techniques called multiple imputations, which I don't understand very well, the estimated adjusted risk ratio came out to 1.15, and now the confidence intervals went from 0.99 to 1.34, and the p-value was 0.07. Now, other secondary endpoints are kind of interesting. Death was 19% higher in the restrictive arm, but again, the confidence intervals were wide, and this didn't reach significance. MI, also 19% higher in the same issue, wide confidence intervals. Deaths due to cardiac disease, or CV death, which was not a primary outcome event, was 74% higher in the restrictive arm. Here, the confidence intervals went from 1.26 to 2.4, so clearly CV death was worse with restrictive strategy. There was an interesting subgroup analysis revealed one possible heterogeneous treatment effect. That is, type 1 MI, the restrictive arm, led to more primary outcome events. That was 1.32, hazard ratio 1.04 to 1.67. As for adverse effects, like the frequency of heart failure, they were similar between the two transfusion groups. The New England Journal of Medicine conclusion has a hedge. This hedge was very similar to the hedge that we saw in the protected TAVR trial. Remember, protected TAVR, as you recall, had a non-significant primary endpoint, but it included a phrase after the declaration of no difference that said, quote, "But on the basis of the 95% confidence interval around this outcome, the results may not rule out a benefit." For the MINT trial, which had a p-value of 0.07, the conclusion read, quote, "In patients with acute MI and anemia, a liberal transfusion strategy did not significantly reduce the risk of recurrent myocardial infarction or death at 30 days. However, potential harms of a restrictive transfusion strategy cannot be excluded." Comments. I like this conclusion. After reviewing this paper for a few days, I really think MINT is now my favorite trial from AHA because it makes you think. The last phrase adds nuance to the interpretation. And here I think common sense and strict statistical thresholds are coming into tension. I mean, I'm biased about blood. In the setting of an MI, when you want to limit myocardial injury, it makes sense to me to have enough red corpuscles to deliver nutrients. But I know, of course, your rebuttal, you'd say, Mandrola, you are the evidence person. There's oodles of studies that find restrictive strategies, blood transfusion saves blood products without affecting outcomes. And I get that. But let's just look at the MINT data without the statistics. Okay, you have more primary outcome events in the restrictive strategy, more MIs, more CV death. Type 1 MIs especially did worse with restrictive strategies. That seems to be a clinically important difference. And there were no differences in adverse outcomes like heart failure. Yes, the lower bound of the confidence interval allows for no difference, but for all intents and purposes, near the entire span of that confidence interval is worse with the restrictive strategy. I would also point to other factors that strengthen my argument that this was a positive trial. A, it was pragmatic. Unlike, say, Paradigm HF with its long run-in periods, longer in the sacubitril valsaltine arm, MINT enrolled a broad group of patients who had both STEMI and non-STEMI, as well as type 1 and type 2 MIs. They enrolled patients with multimorbidity. The trial transfusion protocol led to large differences in the number of blood transfusions, and there were clinically meaningful differences in hemoglobin levels between the two groups. Now, one important caveat, one that I learned from being on Twitter and following trial guru Dr. Sanjay Kaul. Now, Dr. Kaul pointed out that if you take a Bayesian view of the MINT trial results and you use the reality trial results as a prior, remember, reality was the opposite, the restrictive arm did better, then the MINT trial results get pulled towards the null. Now, I have to admit that I can't see an obvious reason why reality and MINT went in opposite directions. Reality was better for restrictive, MINT, the restrictive was worse. So, in sum, if I have a post-MI patient with a hemoglobin of 8.5, and I think a blood transfusion would help, the MINT trial supports a transfusion, but it doesn't compel us to transfuse. That's like the perfect trial. It provides evidence, but allows clinical judgment. And so to PI, Dr. Jeff Carson, and the MINT trialist, I say, very nice work. All right, Factor XI inhibitors took a big hit since the last podcast. Two big stories. First, the Phase 2 AZALEA-TIMI 71 trial, AZALEA for short from now on, which pitted the subcutaneously given Factor XI inhibitor AZALEA versus rivaroxaban in patients with AF and had a primary endpoint of bleeding. AZALEA is a highly selective, fully human monoclonal antibody. Now, as you recall, Factor XI inhibitors are hoped to be the perfect anticoagulant because they have the potential to uncouple hemostasis from thrombosis, that is, block pathological thrombosis while preserving hemostasis. AZALEA actually has some clinical data, too. It was in VTE prevention, venous thromboembolism prevention, after total knee replacement. This was in New England Journal, 2021. There were 3 doses of the drug used versus 40 milligrams of enoxaparin after a total knee. The lower dose of AZALEA was non-inferior to enoxaparin, and the 2 higher doses were superior to enoxaparin for the prevention of VTE that was detected by venography. Now, AZALEA was a similar dose-ranging Phase 2 study, but its primary endpoint looked at bleeding. And the trial was actually stopped prematurely in September because of the, quote, substantially greater than expected reduction of bleeding in the AZALEA group compared with rivaroxaban. AZALEA had 74-year-old patients, a median CHA2DS2-VASc score of 5. The hazard ratio for major bleeding was 0.23 to 0.33, depending on the dose. Obviously, this is a highly significant reduction in bleeding. Here was the problem, though. The trial cannot assess for thrombosis or stroke. There were too few patients and too few events. It wasn't designed for that. But strokes were numerically higher in the AZALEA group, and ischemic stroke in the lower dose was 82% higher than rivaroxaban. Again, you can't say anything about this because there were too few events and the confidence intervals are wide, and I wouldn't even mention this signal, but because of the next story. And the next story is Oceanic AFib trial. In a stunning announcement on the weekend, we received notice from Bayer, the makers of the oral Factor XI inhibitor, Asundexian, and sponsor of the Phase 3 Oceanic AF trial of Asundexian versus apixaban in patients with AF, that the trial was being stopped just 11 months after starting enrollment. The note said termination of the trial was for lack of efficacy. The trial had planned to enroll 18,000 patients, and we were randomizing patients in our office, and it was actually pretty easy to randomize. Oceanic AF was like the DOAC versus warfarin trials. It had stroke and systemic embolism as a primary endpoint. Bayer said that the decision was based on a recommendation from the Data Safety Monitoring Board, who noted inferior efficacy. Now, that this happened so early into the trial is very surprising. But in retrospect, some of the earlier trials of Asundexian had similar signals. That is, there were impressive reduction of bleeding events, but numerically higher rates of thrombosis. Now, the thing about less bleeding is that an espresso or gelato or placebo can lead to less bleeding. That's easy, right? An anticoagulant has to prevent thrombosis. And if a new drug can't do that, well, then it can't win. Now, we don't yet have the data. I assume we'll get it. Now, one question I have is that I don't know if the DSMB was totally independent. There's no protocol paper yet that I can find. One worry that I have is whether the sponsor got to see the data and then they decided that, this isn't going to work out and it wasn't worth the trouble to continue. Nonetheless, I think the final and most important lesson is, again, how we know what we know in medicine. This is exactly why we should have proper, large outcome trials. Because despite the theoretical advantages of the factor XI inhibitors and the decent preliminary data, you need to show benefit in properly powered trials looking at clinical outcomes. Now, note that I used the plural for trials. Now, we use DOX because 4 trials showed similar net benefits. We use SGLT2 inhibitors because numerous trials have shown benefit. We use sacubitril valsartan. Oh, wait, check that. We only have one trial, Paradigm. You get the picture. The failure of Asundexian in oceanic AF is a huge teaching lesson. All right, final topic today is FDA approves another renal denervation device. A few weeks ago, I reported on an FDA approval of a renal denervation device using ultrasound catheter. In my opinion, this was a weak approval because A, the reductions of systolic blood pressure were very modest, and B, the placebo-resistant effect was confirmed for only months. But at least in this case, the FDA followed the recommendations of its advisory committee, which also recommended approval. Well, last week, FDA approved the main competitor to the ultrasound-based renal denervation system, and this is an RF energy-based system called the Symplicity Spyral device. Now, in my opinion, this is an even more dubious approval. First, the FDA advisory committee voted against its efficacy, which made perfect sense because of the 2 Symplicity Spyral sham-controlled trials. Only one was positive, the other was totally negative, and I mean totally. The RF system was tested in 2 big trials, one in which the medicines could be stopped, called Symplicity Hypertension Off. This was published in The Lancet in 2020. It found that the treatment difference between 2 groups for 24-hour systolic blood pressure was minus 3.9 millimeters of mercury. Office blood pressure difference was about 6.5 millimeters of mercury, both of which were statistically significant. These numbers were at 3 months. 3 months. Now, the second regulatory trial of renal denervation with a Spyral system was called the Spyral Hypertension On trial. And this is super confusing. It took me a couple, 3 days to sort this all out. The first paper was the pilot study published in The Lancet back in 2018. This included 80 patients and found about a 7 millimeter decrease in systolic blood pressure in 24-hour ambulatory measures. However, the final paper of Spyral Hypertension On was published in JACC in 2023, just a month or 2 ago. This was totally negative. Here they randomized 337 patients, including the 80 in the pilot. There were about 200 patients in the renal denervation arm and 131 in the sham arm. Now, I am copying and pasting the primary endpoint because it is a little bit confusing. Quote, the primary efficacy endpoint was the baseline adjusted change in mean 24-hour ambulatory systolic blood pressure at 6 months between the groups using a Bayesian trial design and analysis. I think this is an important trial because at least the initial indication for renal denervation would seemingly be as an adjunct to medicines, presumably for patients with difficult to control blood pressure. So Symplicity Hypertension On seems like a clinically relevant study. Let me tell you about this pivotal trial. They enrolled initially 1,700 patients, but ended up randomizing only 337. So right off the bat, they excluded a lot of patients. Patients were followed at 3 and 6 months. These were young patients, 55 years, 80% male, baseline office systolic blood pressure 163. In the primary efficacy analysis, there was no significant difference observed across treatment groups for 24-hour ambulatory blood pressure at 6 months. Bayesian treatment difference, sit down for this, minus 0.03 millimeters of mercury. And the 95% Bayesian credible intervals went from minus 2.8 to plus 2.7 millimeters of mercury. This is really discouraging because remember that in the pilot, which included 80 patients, they had shown a minus 7 millimeter difference, now essentially nothing. The curious thing about this paper is that a graph of this non-significant primary endpoint, nearly identical blood pressures, was published in the supplement, Figure 2. Now you can also look at Figure 4 in the main paper. There's no difference in change in 24-hour ambulatory blood pressure. Now the authors write about changes in medicines. At baseline, there were no differences in the numbers of medicines, but over the trial and before primary endpoint measurement, patients in the renal denervation arm were prescribed fewer blood pressure medicines 6 months, but check this out. It was 1.9 versus 2.1 medicines. The p-value there turned out to be significant, but I'm not sure it's very clinically relevant between 1.9 and 2.1 medicines. In summary, I know it's confusing. The Spyral hypertension off study was positive, albeit with low systolic blood pressure reductions and short follow-up. But the Spyral hypertension medicine trial was split into a pilot study of only 80 patients and then also looked modestly positive, but when Spyral hypertension on was expanded to a larger 300-plus patient recruitment, the reductions of systolic pressure relative to sham completely disappeared. And this is probably why the FDA Advisory Committee recommended against approval. But FDA approved it. So now we'll have 2 devices on the market that have extremely modest effects on blood pressure, one likely little to no effect with medicines, and neither device has data beyond 6 months. Now, nothing has happened yet. These FDA approvals just happened recently. We wait for payers and national coverage decisions, but in my mind, renal denervation has the potential to be the lowest of low-value interventions in the history of cardiology. And it doesn't have to be this way, right? I think there is potential with this device, but we need more data. These trials need to be extended with blinding to at least a year, or possibly 2 years. Renal denervation could also be studied as an adjunct to AF ablation. There's been some small studies, but we need more. It could be studied in patients with high adrenergic tone hypertension. But as it stands now, I am very worried about the low-value nature of renal denervation. Okay, that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, friends, if you like this podcast, please take the time to give us a rating on whatever podcast app you use, or consider writing us a 1 or 2 sentence review. These go a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.